Medicine is a science of uncertainty and an art of probability. William Osler. Most patients imagine surgery as a dramatic event bright lights, tense music, and a surgeon making life or death decisions. In reality, laparoscopic gallbladder stone surgery is more like a well built highway smooth, efficient, and designed to get you safely from pain to relief. Yet, like any road, there are rare stretches where things can go wrong. This presentation is not about fear, it's about clarity because when patients understand risk calmly, without drama, they make decisions with clear eyes and steady hearts. As Francis Bacon said in the 16th century, knowledge is power. I am skipping the general risks of surgery and anesthesia for today's talk. We will specifically understand what are the risks with minimally invasive surgery for gallstones. Laparoscopic cholecystectomy, a mouthful, but in plain words, it's gallbladder removal through tiny keyhole cuts. A camera and fine instruments do the work, sparing patients the last scars of older open surgery. Today's discussion can also be applied to robotic procedures for removing the gallbladder. To be honest, the robot isn't the one performing the surgery. A surgeon controls the arms of the robot while sitting at a console. For a detailed description of minimally invasive gallbladder stone surgery, check out our video What Surgery is Done for Gallbladder Stones. Compared with open surgery, laparoscopy usually means less pain, faster recovery, fewer wound infections, earlier return to normal life. Open surgery is now reserved for the toughest cases, which is why its complications look more severe on paper. Across large studies, serious complications such as major bleeding, bile leaks, bile duct injuries, or bowel injury occur in only a small percentage of patients. The most feared complication, bile duct injury, is rare, usually well under 1 in 100 operations, but can have a big effect on long term quality of life. Why complications happen? Think of the gallbladder's neighborhood as a crowded crossroads of pipes like bile ducts, blood vessels, intestine, and liver tissue. Most layouts are straightforward, but sometimes the plumbing runs unusually close or branches in unexpected ways. Add inflammation, scarring, obesity, or liver disease, and the view gets distorted. Now imagine being a driver at a busy intersection where the traffic lights are malfunctioning. Cars are honking, pedestrians are rushing across, and the road signs are partly hidden by fog. Even the most experienced driver can hesitate, misjudge, or take a wrong turn. That's what surgeons face when the anatomy is distorted. Laparoscopy adds its own limits. The surgeon works with long instruments, not direct hands. The view is usually two dimensional, filtered through a camera. Orientation depends on careful technique and mental mapping. This is why complication rates are lower in experienced hands and when standard safety steps are followed consistently. Structured practice, checklists, and teamwork matter. But here's the catch. Even the best surgeons are human. Perception errors creeps in. A duct looks like the cystic duct, but is actually the common bile duct. A vessel seems small, but is actually the right hepatic artery, which is the liver's main blood supply. These errors are not about negligence. They are about human limits in interpreting complex environments. Psychologists call this confirmation bias, seeing what you expect to see. Add fixation error, which is sticking to a plan despite warning signs, and add overconfidence, and you have the recipe for trouble. Roman philosopher Seneca rightly said, "To err is human, but to persist in error is diabolical." Let's revisit the 2023 ODI Cricket World Cup final. India assumed the pitch would worsen as the game progressed, so they planned to bat first regardless of the toss. But Australia always wanted to bowl first. The pitch turned out to be tricky at first, but the dew made it a batter's dream in the second half. Australia batting second cruised to victory. This wasn't about a lack of skill. In fact, our team was loaded with skill. It was about misreading the pitch and the environment. The Indian team was considered number one, but that wrong assumption led to a cascade of consequences. In surgery, the critical view of safety is the equivalent of reading the pitch correctly. Surgeons must clearly identify the cystic duct and the artery before cutting. But when inflammation clouds the view or bleeding obscures the field, misinterpretation happens. The common bile duct may be mistaken for the cystic duct. One wrong cut and a routine operation becomes catastrophic. This analogy resonates because both cricket and surgery hinge on perception. Skill alone isn't enough. Judgment matters. And judgment can falter when the environment is deceptive. Think of trading in equity markets. Candlesticks look identical to everyone, but spotting the real short term move, bull trap or breakout, makes money. Misread the signals and losses follow. Or everyday life, we judge people on gut feel, often mistaking confidence for competence. Later, reality proves otherwise. The quote shown at the beginning of the movie, The Big Short, which is about the 2008 financial crisis, rightly suits here. It ain't what you don't know that gets you into trouble. It's what you know for sure that just ain't so. In surgery, these perception errors are magnified because the stakes are higher. A misjudgment doesn't just lose a match or money, it risks a patient's health. Now let's get through the actual risks associated with this procedure. Bile duct injuries and leaks. The bile ducts are narrow highways carrying bile from liver to the intestine. The cystic duct is the side road into the gallbladder. If the wrong duct is clipped, bile leaks or blockages occur. Minor leaks can be managed with drainage tubes and endoscopic stents, but major injuries may require major reconstructive surgery to reconnect the bile ducts to the intestine. Though life-changing, many patients recover well when treated in experienced centers. However, if not managed well, it can lead to prolonged disability, blood vessel injuries, and bleeding. Close to the bile ducts lie the right hepatic artery and portal vein. They supply blood to the liver. Damage here, especially alongside duct injury, can be a double hit. Very rarely, this can lead to liver tissue loss or even a liver transplant. Bleeding can arise from small veins or laparoscopic wounds, also called port sites. Minor bleeding is controlled easily, but brisk bleeding may require conversion to open surgery, injury to bowel or other organs. Because laparoscopy begins with needles and trocars, there is a small risk of accidental injury to the intestines or nearby organs. Rare, but serious if missed. Sometimes the small or large intestine may be badly involved in the gallbladder inflammation. This risks their injury during complicated dissection. When spotted early, repairs are straightforward. When delayed, symptoms like severe pain, recurring vomiting, fever, and sepsis demand urgent surgery. Dropped stones and infections. Sometimes an inflamed gallbladder tears, spilling stones. Most are harmless, but rarely they can act like foreign bodies, causing infections or fistulas months later. Surgeons aim to retrieve the spilled stones during surgery and clean all the spilled pus to prevent future trouble. Late issues. Strictures. Late development of narrowing of bile ducts can rarely occur, causing jaundice, itching, infections, or liver problems. It is usually managed with stents or reconstruction surgery. Residual stones. These can sometimes be found months or years later in the bile duct or a small remnant gallbladder, often removed endoscopically. But it might need a repeat surgery. Bile reflux gastritis. After gallbladder removal, bile flows non-stop from the liver into the intestine instead of being stored and released in bursts. So it might back up into the stomach, irritating its lining like a harsh soap scrubbing your insides. Clinically, this is not seen very commonly, but it might need treatment with bile binding medicines and some diet tweaks, and very rarely surgery if it persists. Post-surgery diarrhea. Without the gallbladder, bile drips continuously into the intestine as we discussed, sending excess bile acid to the colon that irritate it and trigger watery stools by pulling in extra water. It's not a very common clinical problem and is usually manageable with medicines, diet, and probiotics. Incisional hernia. Rarely, the small cuts made for laparoscopy can weaken over time, leading to a bulge at the scar site. These hernias are usually minor, but may need surgical repair if they enlarge or cause discomfort. Surgeons lower risks by following structured safety methods. But what does that really mean in practice? It means slowing down when the anatomy looks confusing, calling in a colleague when a second pair of eyes might help, and sometimes even stopping if the inflammation is too severe. In surgery, restraint can be as heroic as boldness. Some backup strategies include subtotal or partial removal, taking out only a part of the gallbladder with stones when the view is unsafe. Intraoperative cholangiography or ICG, which is imaging of the bile ducts during surgery to confirm the anatomy. Conversion to an open surgery, switching to a larger incision for better visibility and control. Rescheduling, postponing the surgery until inflammation cools down. These decisions may sound cautious, but they save lives. Ego, swagger, or speed should never outweigh patient well being. As Benjamin Franklin wisely said, an ounce of prevention is worth a pound of cure. Patients also play a role, sharing accurate histories, following a pre and post operative instructions, and reporting worrisome symptoms promptly are not minor details, they are part of the safety net. Safety in surgery is not just about avoiding complications, it's about building a culture of safety that outlives any single operation. As one quote reminds us, the goal is not to live forever, but to create something that does. In this context, that something is trust, teamwork, and a system that protects patients long after the operation is over. For the overwhelming majority, laparoscopic gallbladder surgery closes a chapter of gallstone pain with a smooth recovery. A few face minor bumps, temporary pain, mild infections, or short-lived bowel changes. An even smaller group encounters rare but heavier complications. Understanding this spectrum reframes surgery, not as a gamble but as a well studied treatment with clear benefits and uncommon risks. Basically, it's a trade off. Fear thrives in uncertainty, and perspective thrives in knowledge. When patients and surgeons meet as partners, sharing openly, asking questions, and planning together, the decision becomes less about fear and more about informed courage. And as Nelson Mandela reminded us, courage is not the absence of fear, but the triumph over it. This triumph is not about ignoring risk, but about facing it with preparation and partnership. Patients who know the road ahead walk it with steadier steps. Surgeons who respect the limits of perception and ego operate with humility and vigilance. Together, they transformed surgery from a solitary act into a shared journey. In 1951, Robertson Davies said, "The eyes see only what the mind is prepared to comprehend." So, the next time you hear about gallbladder surgery, remember, it's not a leap into the unknown, but a carefully mapped journey. And like any journey, knowing the road ahead makes the ride smoother. Thank you for watching Gut Instincts, and thank you for your patient listening. Share it with someone who is planning to undergo this surgery. See you on our next episode. Until that time, goodbye.